Great. So hello, everybody. This is another session of Raja and Neil's book club, where we talk about different chapters from the book on the prevention, recognition, and management of FASD that they edited. And it was released last year. Today, we have Raja, who's going to be talking about service delivery, organization, and models of care. And I'm going to turn it over to you. And Raja, please introduce yourself, how you'd like to be introduced.
Hello, everybody. So I think a lot of you already know me as Raja Mukherjee. I'm consultant psychiatrist. I'm honorary professor at University of Salford. And I set up the National FASD service. I'm still overall service lead for that. Alex tends to run it mostly day to day, mine more outward facing. The book, as many of you know, and probably have heard many times now, came about after a suggestion where I was contacted by Springer, say, is there a gap in the market? We thought there was for that middle range between for clinicians and people who were coming new to the thing, but not aimed at a basic level, which is supporting parents, not aimed at the high end science, but something that a clinician could pick up and use. And I know it's been used more widely than that, but that was the original purpose. That was where the gap was. So Neil and I sat down and we wrote a whole load of list of chapters to do. We got people to write them for us. Helen's on here who wrote a chapter for us and has done one of these. And so we got a whole load of people to participate in that. Hi, Jen. Nice to see you, by the way. But you get to see people you've not seen for a while. And so this is basically a chapter that I wrote based upon things that I had done around service pathway and service provision and my thinking on that subject area as it had developed over 20 years. And to be honest, I don't think my thinking has changed significantly on that in terms of where we've come. And there's different places have gone down different models, but effectively it is something around thinking through what can you do, how do you deliver it, how do we interpret things. Because the other thing about being around 20 years and knowing how things have developed is knowing a little about how diagnostic thresholds are set, and that actually sometimes they're set for clinical purposes, not because we actually know what the cutoff should be. And that the definitions about severity and need and what is a provision and how do we understand some of this and how it fits together. And there's a lot of stuff that we discussed based on some of that learning also that went into the Time Is Now document, which you can download from the National FASD website, which Sandri and I co-chaired. Sandy did most of the work, to be fair, but and I got all the glory. But sort of effectively, it is very much the case that there's a lot of really good stuff in there that can feed into that. So some of the pictures I'm going to use are from the Time Is Now document as well, because it's prettier and it better explains some of the stuff and actually complements really nicely what's in this chapter within the book. So without wasting time, I'm going to share the screen. Right, so effectively what we're going to talk about is a journey, and my journey started by chance. And so I basically came across FASD by accident in 2002, where a lady called Margaret Murch, who's the equivalent of Sandy, basically in Liverpool, some of you may know her, sent me through a pack, well, not me personally, sent our department a pack of information to put onto our website. And that was the intellectualdisability.info website about FASD, because we didn't have anything about it. As the new lecturer in the department, my prof, Baroness Sheila Hollins, not a baroness then, just Prof Sheila Hollins at the time, said, you're the new lecturer, here you go away and do it. And she still will tell that story that it's her fault that I'm doing FASD. And it is in many ways. What it struck me was that there was so little known about it, and there was no clinical pathways, there was no service provision, there was nowhere to go, and how does it fit? Where does it fit into the bigger scheme of things? I read a lot of things, talked to a lot of people naively, because I was young and naive at the time. And then the Daily Mail put me on their front page saying that women shouldn't drink alcohol during a pregnancy. And that was quite scary, because actually you think, what the hell have I got myself into? Pardon my language. But effectively, I said it a lot worse than that. But anyway, we won't go there. But it is the factor that started a journey that has never stopped since then, because you kind of got known for something that you have to carry on. We were able to publish things on the back of that, and I think the thing that we've done differently to many other people who'd been around before that is we managed to get academic publications out on this subject. And it allowed you space to time to think. But in order to do that, I started my PhD. We started seeing people in 2005 based on a research clinic, moved that into my new role as a consultant. But in 2009, we had an opportunity to develop the service in the clinic, and that was a standalone me doing it on my own. And so one of the things that helped me think about, and we're going to come to think about, is a difference, is what is a multidisciplinary team compared to what is a multidisciplinary assessment? Because FASD requires you to do a multidisciplinary assessment, but there was something about, well, actually, what does that mean? And it took me quite a while to try and understand what I was doing and how it fitted into this bigger picture of diagnosis. And we'll talk a little bit about that now. We spend a lot of time talking about that during the Time Is Now piece of work, because it's really important in terms of what is the difference between what a single practitioner can do and how much you need a multidisciplinary team. And it has very much shaped my thinking in terms of service provision. But when we go through, and you can see this is the kind of stuff from the Time Is Now, but it's not just about the diagnosis. There's stuff that happens before you get a diagnosis, and there's things that happen after the diagnosis, and they're just as important. So the support work and some of the things that people in this call do. So Sandy does it. I know Marie Catrick's been doing it for years. You know, she's on the call as well. That actually this is the support side of it, which is just as important, because a diagnosis is not the end point. It's by far, it starts you on a journey for the rest of your life that actually do it. And we need support services around that in order to structure it. A lot of the discussions about how do you get a diagnosis, but that is the start. Now, a lot of the post-diagnostic stuff feeds into multiple agencies, and it's therefore either education in childhood, it's social care, it's employment, it's housing in adulthood. There's a wide range of stuff that starts to kick into that. And so it's not just before that, but also supporting people. And I do a lot of the, how do we navigate the system to get into the system in the first place? Because that's a real challenge. It's just this morning, I was talking to a family in Cumbria who are struggling to navigate the system and knowing where to go to get help, because it's a struggle. And this then comes down to, well, once you get into the system, well, what should it look like? And the challenge that always came back to me was, actually, we can't afford to have teams. We can't afford to have everybody doing everything. And the challenge is, and I am a associate medical director level in my trust. So that basically means I'm a manager as well as a clinician. And I have a responsibility for managing budgets and knowing how we can efficiently get things out of that. So it's not just about saying that you have to throw lots of money, because the reality is, with the situation we are in the country right now and the world economy, you're not going to get multi-millions of pounds. So you think about, how can we do this in a practical and efficient way that allows us to do it? And there's something about, how does that medical model of diagnosis work? So a multidisciplinary assessment, which we've often tailored as the kind of thing that a local practitioner would do, is very much based on me being a doctor doing a medical model without even realizing I was doing a medical model. Because what we do is that we collate pieces of information that other people have done, and we pull it together to come to a formulation and a diagnosis, and then work out what is going on about that individual. And that is what we're trying to do here. So you may take a report done by a psychologist, you may take a report done by a speech and language therapist, you may take stuff from school or an OT, and you collate that together and say, well, actually, these are now fitting the domains that I have. There's enough evidence here to make a diagnosis. And that's where we started, is that for the more obvious cases, that's absolutely fine. And you need to have an understanding of FASD. You need to know the criteria and be able to apply it. But if you can take these information, a single practitioner can collate it. And the example that I give, this is topical at the moment, if you go and see your GP and you have a rash and you have a cough, it could be a simple cough, but it could be something more severe. You may send it from a sputum sample, that may do a blood test. The GP in that clinic or the person in A&E does not do those tests. They will send it to labs and other people, and they will collate the information to come to a conclusion, decide, is this a virus or is this a bacterial infection that needs treating? And so, quite topical in the news, but actually is something where you take a multidisciplinary approach to with one person collating that information and coming to a conclusion. Sometimes they get it right. Hopefully most of the time they do that, and sometimes it may get it wrong, but hopefully by doing that properly, following the criteria set out, that's what you do. Now, there are complicated people where you need a team. And the conclusion that I came to was, it wasn't appropriate for me as a national clinic at the time. It was really a special interest clinic, which got national referrals, to keep sending back to people saying, you should really go and have this result done recently. You should really do a speech and language assessment to clarify exactly what's going on. I got to the point where I thought, we really should be doing this. And so we just managed to get some people together and virtually from other teams who came and did sessions for me. And then eventually from there, we created what was our multidisciplinary team. And so we now have the different members of the team involved in that. And we are a proper multidisciplinary team that comes together. And that is the model that is described in a lot of places. But actually, it's the two things that have to work together, because what you're trying to do is to understand who are those straightforward cases who are more obvious. When I say simple, I mean simple to diagnose, not simple to that they're simple in terms of management, because sometimes the most difficult cases in terms of management are the most obvious to diagnose because there's lots of things there. And then you can start to pull it together, but that experience counts. You can't simply take, and I can't spell individual, sorry, you can't take somebody who's got no experience and suddenly expect them to. Again, this morning, talking even in Surrey in my own trust to new people in our looked after children's population sample, very much seeing this kind of case, very much supported by me, but themselves not feeling confident to make the diagnosis without my input. So you need to have that expertise whilst they grow in confidence. And eventually they will know what to do, but that's something that has to go and is delivered as part of that approach. Again, we talk about this in the chapter in terms of some of the aspects of how to do it. But what this allows you to do is, and we spend a lot of time with this in Time Is Now, is actually put some of what was in the chapter and operationalize it almost. And what we have here is basically, and I always consider Time Is Now as a good practice document in terms of how people can take it and actually apply things, is we apply them to the different domains in terms of things that you can do and tests that you can do at different levels and the type of information that you can collate in different ways. And I'm not going to labor this because it's in the document. I would recommend you look at it. But and Sandy will remember we're doing this at midnight sometimes, trying to get this all out in time. But it gives you an idea of how you can map it. And what I always say to services that are setting up is map what you already have against these domains. You will not fill every single domain. If you've got 6 or 7, or even 4 or 5, that's your starting point. And if you can get enough information there to meet the nice quality standards, we'll come to that in a second, that's your starting point. If you can't, think how you can fill in these other domains and then go from there. Because as a local practitioner, we have to do it in a cost-efficient way. And if we're not going to do that and say everybody has to have a full team and all the resources, I'm telling you now, you will not get it. It just will not happen. And one of the big things that I want to see happen is that everybody locally has access to somebody close to them who has a service that they can get assessment from. And that is crucial. And if we don't do that, what we're doing is we're setting people up to fail if we say people have to have a multidisciplinary team in every local region. Because I can tell you for a fact, having spoken to commissioners, they won't do it. If you say to people, you're already doing a lot of this, let's start with where you're at and then see how we can develop with minimal cost improvement, with the expertise and support, they're much more willing to listen. And it's about how do we get to that point. And different places have started to do it differently. And this is just 2 models as an example of people starting to do this. And so Sheffield, they took an approach where they basically realized that there was a problem. They kind of developed some ideas, and now they're moving through towards commissioning a service. And we were up in Sheffield last week training them how to do this. Greater Manchester, and I know Roisin's on the call as well, have done it in a different way where they took the evidence, they created a process in terms of their alcohol exposed pregnancy and have got a strategy of working through. And currently we're in discussion with them about how do we develop this hub and spoke support. And in the health needs assessment for the Department of Health, can you see my pointer if I go over here? Yeah, is we started off with just as a national clinic and there were lots of local, but what we didn't have is the other regions able to support the local. So everybody's coming straight from local into national. What we need to have is a situation where national can support the development of regional centres where you have the multidisciplinary team for the more complicated people to diagnose and manage. which actually supports those local pediatricians and psychiatrists and whoever those teams to be able to deliver based on what they have. And eventually what we'll hope is that this isn't needed anymore. The plan is eventually that there's no need for a national service and that we will be our regional service, just that like there are other regional services together, and these regional service come together as a community of practice to try and work out what to do. Because if we do that, what we have is a resource which goes around. And one of the things, what this does is it allows people, and I've heard people on this call say many times, we shouldn't have to come down to see you. And I totally agree, is it should be about that. But there is something about expertise and there is something about needing to understand, because ultimately it's about confidence and growing confidence whilst we're developing, and that expertise goes. And it doesn't happen overnight. There is no training for this in standard pathways in terms of the subtleties of this. So people need to learn, and they learn by doing, and they learn by support from experts. And I'm not the only expert. There are other people who can do that, and it's how you understand it. You know, where I'm going to go back a slide. The challenge you have is if you have a set of local people who start to do this, and Brighton to a certain degree have done this in that way, is that they don't have the regional backup, and so they've created something, but they don't necessarily have the infrastructure and the way to approach that. So the expertise, sometimes they've kind of come together to learn, and they're pretty much replicating what I had to do over 20 years. So as we don't need to do that if we get the way to do it, because they've got the local service, they need to have the pathways to support them, because they still don't have access to the broader MDT when they need it, and they don't have access to the wider resources as needed. And that's a challenge that they are going to have to face and work through. You know, it could be easily resolved, but that's a conversation. And the problem with some of these developments is how they actually structure it. And I'm not saying it's a bad thing that they've done it, because it's really good that we've got services going. Don't get me wrong. But it's not just about how we finish things. It's also about how we structure and move things forward. And so we have to think about the management plan. And I know Sandy's told me many times that that's the bit in the nice quality standards she really likes was in there, because what we're trying to move forward is that whilst the first two are very much about identification and history collation in prevention, getting a referral for an assessment, if you have a background history of alcohol or neurodevelopmental problem, getting a full neurodevelopmental assessment and a management plan are the three standards 3, 4, and 5. Doesn't define what that necessarily looks like. And so this service provision model allows you fit into that, but then starts to address the pre-post diagnostic in order to ensure that that actually is delivered. Because we need to think about how we can deliver this in a recession. We need to think that there is more than just the childhood issues. This is a transition thing into adulthood, and adult services are horrendous in terms of supporting a lot of this. I work primarily in the adult world, and I know how hard it is to get anything. And there's a lot of people are adults much longer than they are children. The lifespan of individuals with FASD still is far longer. And so there is no reason why we shouldn't be providing services. We need to work in consideration and think about other partner agencies in this, because ultimately, if we don't support people and families, that's where things start to go wrong. And the management plan fits around all of that. And the service provision is more than just the diagnostics. It is about the supporting people. It is about the diagnosis to understand the individual, and then it's about supporting them on an ongoing basis. So we build on strengths, because we're trying to shift the narrative from a deficit-based model to a strengths-based model. And if we don't shift that narrative, we're always going to set people up to fail. And it's really important that the whole system, and I'm very much about system thinking, comes together to think about how do we manage this. You know, social prescribing, having people around, supported living, all that kind of stuff needs to be thought about. And there's a lot of work still to be done. And so on that, I'm going to stop. And we have, I think, 10, 15 minutes for questions.
Okay, Roger, thank you. I'm always amazed at how you and others are able to summarize so much in such a short period of time. I know you could talk for a great deal longer on that. So I'm going to stop the recording now, and we'll open up for questions.